Good morning and welcome to our monthly webcast. I am Samir Mehta, your moderator, and I'll take you through a most unusual, a genuinely complex coronary intervention, combining a CTO possibly with the use of vascular brachytherapy. Samin, good morning. You and Anu all set for this case?
Yes.
Is it also correct that you've got 69 cases on today? Is this?
Yes. Actually, for us Sinai, the cases number of 79 is the record with the 107 total procedures. So the 7980 is for the Cath lab. And there are additional EP cases and additional pediatrics, which we don't count.
Well,
but overall things are doing good.
I also did something else unusual today, which is very gratifying, and I wanted your feedback on it. I attended a meeting of your nurses and techs in the back room. This must be a major logistical accomplishment for them each day.
Yes. Well, and then the key is that hospital providing enough support.
Now,
that's the most important thing.
The reason I ask this question is, do you sometimes invite or let people from other parts of the world come and watch this operation?
Well, I mean, nurses come less, but during the symposium time, definitely in Japan, during our symposium, we are getting a dozen nurses from 2 hospitals in Japan. There's time to time people have come, nurses from Malaysia and rarely from other places, but more physicians than nurses, and so.
And you've also got cases today with impella, some renal denervation, or
and one potential tower case which we are going to randomize. The Certavi patient, the surgery versus that's fine. The surgery versus because of intermediate risk between 4 to 10 STS, you randomize them to either surgery, SCVR or TAVR. And that patient actually could have been a tower case, but just randomized to surgery. So that patient will go for surgery.
And lastly, is it also correct that Dr. Kinney is doing 34 cases today?
Well, that was little joke. She may be assisting on the probably many of them. But yes, very good volume and continues to be. But yes, that probably, it's a true statement that will be involved directly in more than half of the cases.
Unbelievable. Samin, take us through a very, very unusual case today. And even as you are showing the first couple of slides and introduction, I can straightforward ask you what is going to be the pressing question on everybody's mind. If you had drug-coated balloons, would you be using brachytherapy today?
That's a very good point. That's exactly, you want to put a rotawire now?
And I know this is exactly, because the announcement was there on the website and several people have asked me that question already.
Okay. Now this actually happens to be answer the question of the drug-coated balloon or eluting balloon, which they call drug-eluting balloon. Reason being is that since in US only trials are ongoing is for the peripheral, not for the coronary, but drug-eluting balloon is freely available by 5 different manufacturers in India and other places. This patient actually happened to be a hallmark of what we are encountering at this time in these patients, and this is I start with our slide with supported by and our usual disclosure. Nothing has changed since the last time. Now this is an interesting case. A 63-year-old, case 11 for our webcast with the ACC, had prior CABG and multiple PCIs. He basically has a LIMA to LED, SVG to diagonal and SVG to OM. Both were occluded except LIMA to LED has been fine. So left main and circ has been intervened 4th time just in February. Had 3 layers of stent, present with exertional shortness of breath and chest pain, and has an inferolateral ischemia and near normal EF. Now key is that after the 3rd layer of stent in February in India, by Dr. Kaul, patient received the drug-eluting balloon, sequent balloon for the treatment of ISR of the left main and circumflex. And then he did good for about 2.5 months. I saw him during my last visit to India in consultation. He has recurrent symptoms. We did a stress test. He again has a moderate inferolateral ischemia. So clearly in my mind was that he has developed symptoms, and basically this is the guy, patient who has multiple interventions. He knows when restenosis takes place. Otherwise very good in terms of the lipid, hemoglobin A1C, and so his LDL is 68 and the hemoglobin 3.5. Then an hemoglobin A1C of 7.5. There is no 3.75 flexion of the angioscull. Use angioscull. Here. Then this large high pressure. Now this Cath will just show it to you here, and we want to go through, take us through the Cath. Now start here.
Here's normal LV function. This is his right, native right, which is totally occluded. Patent LIMA, that's going to the LAD.
And does feel a little bit of RCA.
So this is his left main, if you see. It's just a focal ISR right now. It's still, I think, probably a codominant system.
Requires further interrogation by IVUS?
IVUS, we already did IVUS. If you can just show the IVUS play.
Okay, play the IVUS. Yeah. Okay. Here you are going from the circ to the left main. It looks like more angiographically. Look at this, very tight even there. Even in the circ area, within the stent, the complete ring down around the our wire, or I mean basically the IVUS catheter. This is the distal part of the circ, which looks okay, and you can see here. Stop here. No, stop. Yeah, see the 3 layers of stents, 1, 2, and 3. This patient has the 3 layers of stent. The Texas, and then has a biolimus and had a promus. So 3 layers of stent. Yeah. Okay. Keep going. Yeah. Again 3 layers.
Samin, do we know that prior to the use of the drug-coated balloon, was the restenosis focal or diffuse?
Yeah. It always has been focal.
All right.
It's this actually. I would say the first time I saw his all angiogram, the first time was diffuse from left main to the proximal circ, and since then they have stented, and he has restenosed only in that left main area. Truly, if you say angiographically, it's only in the left main area has a restenosis. Now it has been done with the flextome and high pressure balloon dilatation, followed by 3 times the stenting. 3 times the stenting, and last time they did a high pressure and then put a this drug eluting balloon. So that's where we are in this particular case, who is presented 5th time with the DES ISR.
Unbelievable.
And you saw the lumen of the proximal area. Show that the lumen was how much? Small was?
2.8.
2.8. So the left main at that area of the 3rd layer is a 2.8 millimeter square. So the very significant restenosis. Now rest of the circ, how does it look? Then I'll go to the angiogram.
Oh, I mean the...
Yeah, further down. No, I mean angiographically, branches wise and so. Yeah. Yeah, rest of the circ, no. Yeah, here. Go minus. Yeah. Yeah, I mean circ actually, I don't know which OM was that the top OM which we are seeing, that's where the bypass was. But there seems to be few occluded small vessels.
Branching LPL is okay.
Yeah, branching LPL is fine. And the focal restenosis of the left main angiographically, because IVUS point of view maybe proximal circ also, but that becomes important point, particularly when you are using a brachytherapy, and that is what we'll talk about. And this is what our plan here in this case for the refractory instant restenosis.
So Samin, it is absolutely not true that all brachytherapy goes to the Washington Hospital Center.
Well, I actually very interesting. Beginning of last year, because I had 2 patients back to back, which had a recurrent restenosis of single vessel. Both were actually RCA, and I sent those patients to in February to a 1 vessel bypass. One guy got a RIMA to RCA, other one got a vein graft. And actually one of them, the one with the RIMA, came back within 6 months. But the issue basically was that beginning of last year, we realized that we need to resurrect the brachytherapy issue. So we started brachytherapy program last year beginning, and now actually at present, according to because only one brachytherapy company at present, Beta Cath with the Best Medical, Novost has been taken up by the Beta Cath and Best Medical, that we are the highest user of brachytherapy in United States. So, but one thing sure, anything we start is becomes the highest because of the frequency of the cases, the number of cases, and so at present we are performing about 6 to 8 brachytherapy cases per month.
Well, that is a revelation to me, and I thought I had understood most of your patient manifestations before. Samin, take us through what are you going to illustrate today in your points. In the meantime, welcome to our viewers in Beijing, 8 p.m. in the evening, and to Euro PCR attendees, lunchtime there. Hopefully, you'll be able to catch some of this too.
Yes, and appropriateness clearly because of same class 2 to 3 symptoms and large moderate area of ischemia and maximum medical therapy makes it appropriate. Now what I am going to talk today, just to outline in this particular case, we want to do things which had not been done to this patient. Patient did not have, as I said, patient had a flextome, patient had a high pressure PTCA, had a multiple layers of stent, and has a drug eluting balloon. So our goal here today would be to do a rotational atherectomy followed by angiosculpt, high pressure dilatation, and then intravascular brachytherapy. So that will be our point in this particular case, and I'll just take you through quickly on two important aspects which we talk all the time during our this symposium webcast. 2 points. One is the DES restenosis, the mechanism and treatment, and the role of intravascular brachytherapy where we are in this current era. Now, clearly, we know the instant restenosis is rarely a recoil. It is the intimal hyperplasia unless there is a anatomical factor of the stent deformation, stent fracture or so, but still they all lead to through the intimal hyperplasia. We have learned over the years that patients, when we do a PTCA, the whole vessel shrink and decrease the external elastic membrane causing restenosis, but with the stent, basically instant restenosis, it all remains, the external elastic membrane remains the same, maybe even bigger, but all intimal hyperplasia. And whether it's a BMS or DES, same mechanism apply. The very important is that what is the angiographic pattern of the instant restenosis, because that determines your subsequent outcome. Whether it's a focal, diffuse. In the BMS, we used to get quite a bit of diffuse, but now with the DES, we get quite almost 50-60% as a focal instant restenosis, and rare cases of total occlusion. And the diffuse ISR could be intrastent or proliferative. Very important. Proliferative means it's extending beyond the stent struts, and this is actually a landmark paper which is quoted from Roxana Mehra in Circulation. The type of ISR associated with repeat TVR. So one, you had type 4. These are the data on the BMS, that almost 80+% will require repeat intervention once you get to the type 4 total occlusion, or diffuse proliferative, almost 50% in the BMS era. Now, very nice review article by George Dangus, instant restenosis in DES era, really puts, and I added many of them in this, that why DES fails for that matter. We are not talking about stent thrombosis. That has been a focus at the time. But today our focus is DES restenosis. What makes it happen? One is a biological, but some of the drug resistance, or there is an insufficient dose, or hypersensitivity has been implicated because many of the DES pathologically have high eosinophils and macrophages. Therefore, it could be the factor, the biological factor. Second is mechanical factor, and the two of them I have made a little bigger font size: stent under expansion and stent fracture. Stent fracture more and more coming now as a major player in a focal DES restenosis, and of course your non-uniform stent strut distribution in calcific lesion. So one area your stent struts are closure, other side separate. Separate area, the drug doesn't diffuse enough and cause the intimal hyperplasia, and so causing the non-uniform drug elution. And then lastly is, then of course polymer issues, the technical factors, where many times when putting a stent you have a barotrauma into the non-stented segment, and other is stent gap or stent distortion. If you don't have the longitudinal distortion, and so has been implicated in the mechanism of DES ISR, and of course that you have not covered the lesion completely, and these are the various mechanisms for DES ISR. Patient characteristics and the lesion and procedural is shown here. Basically, we know multiple long lesions, total occlusions associated with higher restenosis, and so. Now, what I have done is, we know that second generation stents are better than first generation. All the trials of everolimus eluting stent or zetolimus comparing our Cypher Texas, your restenosis rate is about half. But what about in the second and third generation stent? We have 3 randomized trials. Resolute all comer, we have 24-month data. 20 trial with a 12-month data, and then platinum trial with a 36 months data. As you can see here, I have put the drug elution ZES or EES, or platinum chromium or cobalt chromium with EES in both of them, and the target vessel failure, which include the target vessel revascularization, ischemia driven, MI and death, and of course or lesion issues, so the TLF or TVF. And you can see here the height of these bars identical in all the trials. So you can say safely at present that there is no significant difference in the FDA approved second and third generation stent in terms of the TLR or restenosis. There may be some data to support that lower stent thrombosis with the everluminous eluting stent in the giants, but restenosis point of view exactly identical as shown here. So now you have the restenosis. What you do? Medical therapy, of course, many refractory cases can go for bypass surgery. But we try to do re-PCI, and of course, using a high pressure balloon, the cutting balloon or scoring balloon, drug eluting balloon, the laser, rotablation, restenting, and brachytherapy. Now, question is, many of them have been looked into. One of the issue is that if you have a restenosis of the one drug, should you use the same drug, another stent, or should you use a different, which is homo stent versus hetero stent. It was looked into the ISR Desire 2 trial, where they looked into the all patients with the sirolimus eluting stent restenosis, randomized to paclitaxel versus sirolimus eluting restenting of these cases, and basically found absolutely no difference, as you can see in the angiographic and clinical restenosis, 500, 450 cases, as well as TLR, and no issue of the stent thrombosis. So basically you can say that whether you have one drug restenosis, that you use same or other, no difference in outcome. Then we go to the next, and this is where your question came. What about the drug eluting balloon? And you can see this Eyesight Desire 3, published in Lancet 3 months ago, really puts everything in perspective. This is a 1-year follow-up of about 550 patients. All were sirolimus eluting stent restenosis, randomized to paclitaxel eluting balloon, paclitaxel eluting stent, and balloon angioplasty. Only drawback here is that none of the patients received second or third generation DES. But having said that, look at the death and MI identical. But once you get to the TLR and TVR, clearly the PTCA fails. Majority of them were cutting balloon. So double the restenosis in the TLR, TVR, and within paclitaxel eluting balloon versus eluting stent, you have advantage over the restenting. So seems to be the paclitaxel eluting stent has a non-statistical or trend towards better outcome compared to the paclitaxel eluting balloon. So this is the only good randomized data we have in this field, comparing the DES versus paclitaxel eluting balloon. And of course these are the survival curve. And then they're just coming back to the whole issue of the drug eluting balloon versus standard treatment. There is a 4 major trial actually. PACO Cath ISR, one was not a randomized, 2 was a randomized, about a small number of patients, 340 plus. And the DB and conventional treatment, you can see that if you are using a PTCA, only your drug eluting balloon is better. More importantly, cause lower MI. You say, how can it be lower MI? Very simple, because less restenosis, less MI. And of course, the lower TLR in this randomized trials only I included. I did not go for any registry data, randomized trial of the DEB versus conventional treatment. Once you go to the D in the native vessel and you against DES, drug eluting balloon fails. So the drug eluting balloon, good data in the instant restenosis and some data in the side branch, but still this field still need to go further. Now, then question is, what about restenting? Restent, you can do it as a stent sandwich we call, but has been associated with no difference in terms of the TLR, but higher myocardial infarction. So we had done second, third layer of stent, but they caused little higher myocardial infarction. And of course, if your patient comes back soon or diffuse, have a high predictor of subsequent restenosis. Therefore, now then come back to the last point of the today, that is the brachytherapy or vascular brachytherapy, IVBT or ICBT. Remember, when we compare the DES with the IVBT in the BMS restenosis, 2 major trials, CISR with using the Cypher and Texas 5 using paclitaxel, showed DES superiority over vascular brachytherapy for BMS ISR. So the VBT became obsolete. That is what we did. At Sinai in 2005, we stopped using the brachytherapy. But now we know because of the more widespread use of the second and third generation stents, which are safer, effective, more and more patients are coming back, and basically brachytherapy works by preventing intimal hyperplasia and of course less acellular matrix of the intimal hyperplasia. That is how the VBT works. At present, only one source is available, beta Cath, with the Novus, which is the 90 strontium and 90 yttrium beta radiation. It comes whole package, and of course you require radiation physicist and radiation oncologist to be in the room, and it has 4 parts. One is the jacketed radiation source train, you call it JRST, then the transfer device and the delivery catheter and accessories, and we'll show this practically in this particular case. And of course, how long it's left between 3 to 5 minutes, this source train into the lesion based on the length and the size of the vessel. So particular gray delivery of the radiation is accomplished during that time period. Data of the brachytherapy for DES are very scanty, and only the data we have actually from Washington Hospital Center by Ron Waxman. Initially they compared, not randomized, 56 cases, 61 cases of IVBT with a 50 case of re-DES. As you can see here, both had a higher restenosis, but some advantage of the IVBT in terms of the overall MACE with a decrease in the TVR, no difference in stent thrombosis. So they showed in the rescue registry the trend towards better outcome with the IVBT compared to the standard non-randomized registry of the re-DES in the comparable patient. Now they actually showed now the 1-year data that event rate occurs, because these are the high patients that come back with a few frequent time, almost in 20+% of cases with a TLR 10%. So, and if you use this for, if the stent has been used for restenosis versus has been used for a de novo, the subsequent outcome depends, of course, simple versus complex, the complex having the higher restenosis. Now, I can tell you on Mount Sinai of the last year in 2012, we did 50 cases with a 9-month follow-up. We had 2 patients with MI, no death, no stent thrombosis, and TVR in 4 patients. 1 patient went for surgery. And of course, people worry about the cancer. Of course, it's still very early to see that where this is going to go. So just to sum it up, while we are getting ready, if I had to say algorithm for treatment of DES restenosis, I think this is my the take home, that exclude mechanical causes, under expansion, fracture, deformity, compression. After that, your focal versus proliferative is the difference. Because as long as you're within the stent, I think your treatment algorithm should be the same, which is on the left side. High pressure balloon dilatation, or drug-eluting balloon, or cutting balloon, or scoring balloon, and then of course restenosis, then only you put a DES. Or if it again come back focal, you can still do a PTC again. If comes back, then only you do a re-DES, and of course if becomes a diffuse 3rd or 4th time, then go to the intravascular brachytherapy. Compared to proliferative, where it's going outside the stent struts and total occlusion, there I would say you need to recover that area with the another DES. So you open the lesion with a high pressure or cutting balloon and do a re-DES, and if restenose, then go to brachytherapy. So now you have 2 layers of stent. Some people may go to 3rd layer of stent and then only go to the brachytherapy. Then clearly that once your brachytherapy should be for 2nd or 3rd DES restenosis or diffuse restenosis 3rd plus time. And of course, if patient comes back after brachytherapy, then you have a choice. Do you go further or send them for coronary artery bypass surgery? But clearly, we do not have any good long-term data of the randomized in this field which to guide us that what we should be doing in these cases. Having said that, now Anu, you are ready? Okay.
Yeah, we have the 175.
Samin, excellent review of unusual and a difficult topic. In particularly, I found the algorithm to be very beneficial, and hopefully our viewers will find it that way too. Some other comments I have to make. Samin, registration going on for your complex vascular course?
Yep, fantastic with quite nicely. We are actually about 90 plus this year at the same time compared to last year, and yeah, it's happening quite well.
Should
so
we
right now we have a dedicated days, one for the nurse technician, one for the vascular, one for coronary, and the 4th day combine both vascular and our coronary.
Excellent. Are you planning to show any vascular brachytherapy there too? Unusual cases, they
but
don't.
We'll show, yes, for our coronary cases, absolutely. We actually have 2 patients lined up, whether we show 1 or 2, but we definitely will show brachytherapy in our during our symposium. Well, I think it's a very useful modality, particularly same. To me, threshold is, and those cases which we showed, is the minimum 3. That patients, the 4th recurrence, what we have shown so far, 8% event rate, but this may be still too early because they need to be followed further.
Samin, is that a 175? We didn't go into the details of the size of the burr.
Yeah, this is a 175 burr.
Right, okay.
Yeah. I think we have to go all the way down.
Yeah.
Right.
Yeah, bradycardia. Yeah. Okay. Give a
Cough.
Give atropine 0.6. Give atropine 0.6.
Wake up. Cough.
Yeah, here.
Cough.
Come out of the
Big
vessel.
cough.
Come out of the vessel.
It's okay.
Yeah, clearly that despite the good circumflex, because RCA is total in this particular case, that created this asystole and so. But now we are given atropine rather than putting a pacemaker, which is okay. And we'll go through all the whole segment, because once you're doing a radiation which takes over the 60 millimeter segment, we want to take care of the entire segment, because we don't want it to come back for this area, yeah. But don't go beyond the stent start.
Yeah, there's a lesion just at the distal edge of the stent. Okay, good.
We'll be okay now. Good.
Anu, how did the patient fare with the second run? He did much better.
I think we just did it very quickly.
Excellent demonstration, fantastic skills, amazingly fast and effective management of this profound bradycardia. This particular incident, I think, should convince the people about the value of deep experience. Not only are you able to accomplish a procedure very safely, but to manage any of these. Anu, fantastic job.
Thank you.
Yeah, now also it happens in many of these cases, we try to exchange the rota burr and so, because that the guide keeps coming. If it's a proximal segment, I think it just take out as Anu has done. Take out your wire and then just rewire it.
I think, Samin, it deserves a mention again, the amazing proficiency both of you demonstrated. Most people would have, if not necessarily freaked out, but this would have shaken them up, and here you go, you managed it effectively and proceed on with confidence. Anu, fantastic. Samin, this patient I understand is from India?
Yes.
Mount Sinai gets a lot of patients internationally referred?
Well, actually, what they were sharing with me, that for the procedure, actually highest number we get at present is for urology. So David Samadhi has a very good reputation. He gets about 58, 55 to 50.
There is another doctor I know in the hospital. I don't know if he has this kind of a reputation. You may be knowing him, Samin Sharma.
We are actually now, I would say that I'm having almost one case every week coming from, actually, the last week we had 2 patients from Pakistan. Another patient coming end of the month for mitral valve replacement, the repair and maze procedure with Dr. Adams. And there is one patient coming will be like first week of June for TAVI. And so, but yes.
And the hospital has all separate package deals for these international patients?
They are very separate and makes it very easy. Like the same thing, there's no reason to send the money before this. This patient arrived yesterday.
60, right?
We are done on the phone. Go a little further. Yeah, we are done. We arrange
3.5, you want 60?
Yeah, so 60, yeah. We arrange everything just yesterday.
3.5,
nothing had to be advanced. The patient, by their credit card or bank transfer, they do it right away and just do it right after arriving here. They not even have to worry, because many centers I know, they try to get the funds before patient arrived in the country. But for us, it's fine. This is a 3.5, 10 millimeter angio sculpt, which I gone with a 16 atmosphere. angiosculpt I used rather than the flextome in this particular case because they have already used the flextome before.
Right. I noticed a very heavy emphasis in this case. You are not trying to reproduce anything which was done before.
Right.
To our viewers, once again, if you missed any previous webcast, you can go back to the website, you can post your queries, and of course do continue to watch our companion webcast archive, which is also tomorrow, hosted by Dr. Prakash Krishnan. All your questions, please direct them to info@ccclivecases.org.
Yeah, and the advantage of the flextome here is, the angiosculpt that I can go to 16 atmosphere, 16, 18, that's the key. Because in this case, idea is, but I don't think it's an issue about the stent under expansion. We saw it. It's a stent is nicely expanded, just a intimal hyperplasia, failure of, here now we do.
Right, even by IVBT, there wasn't any suggestion of any under expansion.
Pull back the guide.
Yeah. And see that while we are doing it, we have pulled the guide out. Very, very important. So that you again 16 atmosphere, your guide out, and dilatation patients right now tolerating quite well. It's a 3.5. I don't think we need to go to any further.
Let me come out here. Go.
Samin, help me understand the full logistics here. You've used the rotational ablation, you've used the angiosculpt, now high pressure balloon.
No, we're not going to use high pressure. You're right.
This is the...
Yeah, this is it. The same angiosculpt to 16, 18 atmosphere.
Okay,
16.
My question to you is, how vital is preparation of the site for vascular brachytherapy?
Actually, it's not that important.
It isn't, all right.
Yeah, that's the key. That's a very good point. We learned in our BMS day era also that as long as you bring it to your 30% and so, what IVBT will do, it just will freeze that lumen. And that's the key. It's just going to freeze. Whatever you leave, 30% will remain 30%. And we actually have few cases who have come back with the, after many years of IVBT and so on, they did quite well. Ready?
Yeah.
This is looking...
the only thing is the distal.
Yeah, the distal I think needs to be done, no? You can't really...
Yeah, but so that's a non-segment.
Yeah.
Right.
Yeah, but that now question always comes that area of if you take this off.
There is an FEM. Why?
Yeah. This actually was empirically also started on Procedural there in India. He has been on clopidogrel, actually BID dosage in the past, but they put him on 10 milligram. Of Procedural, that's what he's taking, and we'll do the platelet testing also.
Anu, no issue between cases done with the brachytherapy and bivalirudin?
No.
Yeah,
except you have to be careful. Suppose you're doing a long segment. You mean you have an entire RCA total occlusion. You just have to be careful. If you are more what they expect you to do, you want to do the distal RCA 60 millimeter because they come in two. We have a 40 millimeter train or they have a 60 millimeter. So if you are doing entire RCA, then if you are doing distal and then you are doing proximal, you just have to take your catheter out, flush it, and then go back in.
Excellent.
But your point is well taken. Remember back in early days of IVBT and bivalirudin, I think part of that was that we were not loading them good on antiplatelet therapy. There were case reports actually. Ron Waxman that time reported on bivalirudin that it's having a higher thrombus rate in the bivalirudin and IVBT cases. But I can tell you, since then our experience has not been like that. And the key is that after we have done the brachytherapy, these patients we actually categorically continuing the dual antiplatelet therapy lifelong. Right or wrong, because we don't know.
I think this guy is a pacemaker.
Yeah, like little verapamil. I give little verapamil. Yeah, he's very sensitive.
Yeah, a little unusual at this case. I could understand during rotablation, but...
No, because I gave a little verapamil, there was a little spasm at the distal segment.
Right.
So just because of that, the question is it true? It's our plaque movement, and so even if it is, what I'm going to do in this particular case is that we will, if we have to stent it, we'll do it in the end after brachytherapy, because clearly the brachytherapy, our idea would be to not to stent, and even if it remains moderate, we'll leave it there.
Just a balloon maybe.
Yeah, Anu, I like that idea. I was thinking about it also, that you
just
probably all,
Just a little squeeze of
Yeah.
4 atmosphere, no
Yeah.
more.
Okay, again, give me a
275.
non-compliant.
Yeah, 275, 12.
3 is good. It's a big vessel.
Dissector, unnecessary.
Yeah.
Okay, 3
3/15 or so. 3/15 quantum. Yep, quantum apex.
Samin, how is the program coming up? The controversies in cardiology moderated by Dr. Fuster.
Yeah, actually it is a big hit, particularly with this every month we are the visiting professor, and it is now they are all archived, so people can actually have not been archived yet, and by July we'll have a separate web address for them, but it has been a tremendous positive response.
Yeah, as I've been proctoring in many international sites, Dr. Fuster is quite a legend there.
And it all happened through our webcast, CCC webcast.
Right. Well, this has been, I think, partnership with ACC. You cannot do better than that. And from what I understand, today's website is available at the end of the week.
Yes, absolutely. Yep. So now basically we need to get a good balloon result. Putting a stent is simple, but idea is avoid stenting in this case.
How much would your concern here be also of this patient just limiting the cost here? Is
No.
that a concern? Not
No,
much?
because this is the package.
All right.
Whatever we need to do is all included in this. And basically just go at a 6 to 8 atmosphere, crack the plaque, leave it at half of it for about 60 seconds, and should be able to give you a good results.
And this is the 3.5?
It's a 3.0.
3.0, yeah.
3.0, 15 quantum apex. We started at 8 at 10 atmosphere and left at 5 for about 60 seconds.
Samin, a question coming for you. Is geographical miss a concern with beta radiation?
Well, I mean, that's why you need to use a longer train source, always. That has been the, hallmark or enigma in the beginning. Then we learned, so that every case, or majority of the cases which we do here, we are using the 60 millimeter train source. So that has enough area for your the coverage delivering the beta radiation.
And you do not, looks wonderful.
Yep.
I think that
Part
is...
of that could be just vertical displacement of the
Plaque.
axial distribution of the plaque, which
Right.
has been shown with those high pressure. Okay, now once we are ready, we have our radiation physics.
So you don't, the Cath lab today with beta radiation and Best Medical and the way it is configured does not need to go into combat mode, that everybody has to leave the room and all sorts of things are not needed?
We
That's
don't
it.
leave, no.
And they make it very simple. Our radiation colleagues are very, very cooperative. Look at this. People say radiation, they want to go to radiology because they don't have to wake up at 8 o'clock. But they are here at 7.
Well, they can, they work 24 hours a day,
Remote.
reading, yes,
So
it's
just,
all
this is
teleradiology.
This is a long catheter.
Yeah, but
This is unusually long catheter, but just
that's the catheter. You just
with a very short monorail.
I am sure the radiologist will interpret that, look, when you sleep, they are interpreting from home.
And that's true.
So this is the radiation source?
Yes.
No, this is the catheter.
Okay,
Delivery
all right.
catheter,
Yes, the
beta
delivery
rail.
catheter, okay.
They call it a 3.5 French beta rail catheter.
And then what you see is there are markers.
Easy tracking of it?
No,
Not so, okay.
Nothing
So
is-
little bit of nothing
little
is
bit.
easy with,
nothing is easy.
Yeah, well, now I get a sense of it. Let's see how it makes that pass. Sometimes do you end up using buddy wires
Buddy
and those
wire,
kind
We
of?
may
Okay.
have to use a buddy wire. Why did they bring this long catheter?
Which one?
This is longer than usual.
No, but that's still okay. The usual height.
Let us the fielder wire then. Take a
all
deep breath, sir.
Samin, from what you know, is gamma radiation used anywhere in the world now?
No, gamma is down.
Completely gone.
Since it's a short monorail, I think what we'll do is let's try with the. Oh, no, it's not going.
No, but I know, but I'm saying leave that there side by side.
No, side by side, you have to go on the fielder. don't know why they brought this crazy long catheter.
No, but is there a different lengthwise?
Yeah. This is a different long. It's very long. Why they brought the 260?
We always have been using 267, right?
No, 180. This is too long.
This.
You can.
We have the shorter one, then let's get the shorter
They
one.
can inject it from the holding area. That's how long it is.
Yeah, therefore basically the catheter length are two different. I thought we were just using one. Yeah, good. Let's try
Samin,
it.
what is your thinking on this area? Is recurrence multi-layered presentation of instant restenosis a big enough problem that some other hospital should reconstitute their
Well,
brachy?
I was told actually in last 1 year that from 2005 to 2011, that 2011 there were no new centers. Right now there are actually, how many centers are using brachytherapy in the country? 10, 11? About 20 now. There were people are starting, because this is kind of situation what we have is the issue basically. But the length should not affect us to going.
It's a iatrogenic disease.
Yep.
20 centers, I'm actually quite surprised, and I had no idea that your own individual volume was so much.
Yep. Yeah. So therefore, it worked out. Went on the
Buddy wire was
the
the-
fielder wire and the buddy wire. I mean, but key is that we know anything you want to go through the stent struts, it's better. Question is you want to do pull back a little bit. Yeah. That
No.
do you want to go? You go on a hydrophilic wire. So we need to pull back because we have to do within the stent, and there is less problem distally. We have to cover proximally.
Okay, that's good. No, you need 3 millimeters restore. Okay.
No, we need to pull back. Little more.
Outside the guide.
Come up to the ostium. Yeah, I know. But that's yeah. Okay, will be good. All right. Now you can see that what I need to see is very important here.
take a
in
single-
this, yeah. That first you need to see that your source train will be able to come, so that you disconnect as we are doing it here, and try to see back and forth. That there is no kink in the system. You need to bring the guide a little more. Yeah. See, you're able to advance so that there will be no resistance on the radiation source to come. So you try to see back and forth.
Go this way. Make sure it
Yeah,
makes
that's
a
it.
turn.
That's it. There's nothing there.
Turn. Okay, good. Out.
Okay. All
But
right.
you could see the marks.
60.
Yes, we can.
Yeah. So they.
60. We need a 60 length so that we are using 30. You know, total length is about 30, 35.
Anu, almost every case you're using is 60.
Yeah.
No, 40 or 60.
Yeah. I mean, almost 90%. I'm on the longer side, because knowing that these all cases have, by the time they come back to this fourth restenosis, they have multiple stents, and so longer segment, so that we using there is a 30 available also. We don't even carry. We carry only
They
40
only
and
have 40
60.
and 60.
60, and majority are 60.
And what you would probably recommend Procedural in this case, probably beyond.
We've done the planning.
No, in this case. No, in this particular case,
yeah. On
Because
Procedural,
it's
no?
already there. We are
Right.
testing for the sensitivity. But in this case, I'll change it to a 5 milligram.
Right.
Because otherwise bleed quite a bit. And after 1 year, maybe switch back. Because remember, the data of the 12-15 months are only. The long-term data of the Procedural not available. And we know that in the beginning, in the Triton, there was some issue about some adenocarcinoma, some soft tumors in the Procedural group. Although subsequently they found it was a chance occurrence, although p-value was 0.08. Yeah.
What happened to that?
Not there. Yeah. And therefore, we'll try to keep that only for 1 to 2 years, 1.5 years, but not long-term further.
Samin, staying on the topic of antiplatelets, what is the percentage of your cases on clopidogrel versus the newer agents?
Yeah, I would say 70, 25, and 5. 70% is still clopidogrel, 25% Procedural, 5% our ticagrelor. Reason being is that still we, ticagrelor issue is many times not available by insurance, and so on and so forth, and the symptoms.
I have converted almost all my patients with STEMI on ticagrelor. Are you using it for ACS and STEMI?
Yes, those yes. Yes, it's a 3.5 millimeter vessel.
What the hell this? This is crazy.
Yeah, it will be 4 minutes 48 seconds.
Okay, move this.
The dose and everything is calculated by the radiation oncologist?
That's right. Okay, you're ready to start? Good. Now when it is going, then don't put your hand at the Y connector. Always show the small picture in a picture, guys. Yeah. Picture in a picture.
Sine.
Yep.
So 4 minutes 48 seconds of dwell time.
Yep. Right here. It has arrived. See that?
The train has arrived the station.
Train has arrived the station.
We can do another case and come back.
Okay. Yeah. So that's it. Leave
4
it there
minutes.
for about with the length and the vessel size.
So we have pulled the guide out. ACT. How much? 320.
Yeah, in the end, now there will be some which we call instant restenosis, some plaque protrusion in the end. There actually the data have shown in the past, but that is the BMS. That you see some plaque protrusion, now you do a PTCA versus don't do PTCA after the IVBT for BMS ISR. And it showed that doing a PTCA is not good. So that even if you see a little plaque protrusion, leave it. So that is kind of instant restenosis. So that happens. But as long as it's not compromising flow. So if it become more than 50%, so that you have to go with the tack it up with the balloon again. If not, you leave it there, and the brachytherapy should freeze it accordingly. Now, since we are still in the holding mode, and we'll be reaching quickly to our 5 minute, our 9 o'clock time, we just want to go complete our rest of it, particularly go through the question answers, and so this patient is getting a beautiful demonstration of the IVBT. We can go to our slides so that we finish our in a timely fashion. As you mentioned that the case is white, yeah, keep it there. Now, the issue always will remain that homo versus hetero, in my opinion, based on the literature at present, there is no data to support that the different contrary drug will work better. So it does not matter whichever it is. Now then, so the take home message in the mechanism and treatment of DES ISR and role of IVBT. One is, in the current era of widespread DES use, especially second, third generation, we are increasingly encountering refractory DES ISR, third, fourth or fifth time in minority, in about 2-3% of cases, despite various optimal interventional strategies like this patient had. Drug-eluting balloon has some promise in these cases, and CABG may be appropriate in these refractory cases. Answer will be the bioabsorbable stent in future may limit this problem, because hopefully the recurrent restenosis will be less, and then will be not a metal at follow-up. Then the vascular brachytherapy seems to be effective in refractory DES ISR, especially after second and third generation DES, but long-term and randomized clinical data are needed before establishing its role in the Cath lab in the current era. And actually we are trying to collaborate, knowing that the Washington Hospital Center also very active in this technique, that randomize the diffuse ISR at the third times or more to a conventional treatment versus IVBT. So that really will be a way to go to answer this question in a randomized way. So coming back to our 3 questions, one is the ISR Desire 3 trial showed one of the following: that the DES was inferior to re-PTCA, the drug-eluting balloon was inferior to re-PTCA, re-PTCA had higher MI than re-DES or drug-eluting balloon, or drug-eluting balloon and re-DES were superior to re-PTCA. And I'm sure we emphasize those points, and answers should be simple. Second, following are the usual mechanisms of DES ISR except recoil, stent fracture, stent deformation, and intimal hyperplasia. The last, the vascular brachytherapy works by following mechanism in treatment of DES ISR: by enlarging the extraelastic membrane, by making the vessel weak, by plaque protrusion, prevent subsequent intimal proliferation, or by positive remodeling of stent. So clearly, to get CME and our archived cases, we need to answer those questions and get your 1 hour CME.
Samin, there is one important
30 seconds.
aspect which we have not discussed in this case today. What about the reimbursement for these patients, including compensation for the radiation oncologist?
Yeah, actually it's a reasonable. Only problem is it's not recognized as an ambulatory procedure. So you have to admit every patient with a brachytherapy so that as an outpatient is not reimbursable.
And so how in your institution it may be different, but what about compensation for the radiation oncologist?
Yeah, the radiation oncologist, the fee is about $800, and the equipment, the procedure itself is about $3,000. And the DRG becomes, the point is the DRG is only of PTCA, or in this case now the atherectomy, because the rotablation has become the separate the CPT and DRG code now, so that but if you just do a PTCA, it's only of PTCA. So in some cases
Well,
you lose money.
my reasonable conclusion from what you just mentioned is that with the existing cuts in reimbursement, the radiation oncologist makes more than the interventional cardiologist. Result looks good. I'm particularly
trying to
happy
get the-
about the distal segment.
Yeah.
Slight recoil there, or
I mean, that
maybe
we
a slightly different view.
Yeah, but just minor, which we expect. But you know, anytime you wait 5-10 minutes after your intervention, overall looks very good.
Right.
No dissection, fantastic, and in every way. And we finished in time. We started about 3 minutes late, but we finished exactly in time.
Anu, final comments from you first.
I just wanted to, I think...
I want you to share with us, you know, you've got profound experience also with the brachytherapy. Some teaching tips there?
No, first let me finish the rotational atherectomy tips, that what you saw, how we manage this case. I mean, in this case, since we knew the RCA is total and then we are doing in the circ, starting from the left main itself, maybe first we needed a pacemaker. Suppose you didn't have a pacemaker and you know the patient is going into bradycardia, you stop for a second, and then, I mean, the quick thing that you can do even before giving atropine is wake up the patient so they cough. The reflex will increase their heart rate. But more important is to give atropine and try to finish the case. Otherwise, what's going to happen? You have to take the entire burr out, then try to get the temporary wire. So by the time I think resuscitation just with atropine, coughing, you saw how we quickly finished the rota. And the other thing that we did was did not wait for the rotational rota burr to normally come out with the dynaglide and out. The entire burr and the wire, we took it out so that we are not waste more time with the burr in the vessel or the wire there, trying to cause more bradycardia. That's one tip about rotational atherectomy. And just with angiomax and brachytherapy, I think if you are, as long as your ACT, you just have to make sure your ACT definitely is about 300 if you are using angiomax with this catheter that is going to be dwelling there at least for 4 minutes. And if you are doing long segment, you just have to pull back, flush, and go back in.
Excellent, Anu. Fantastic skills. Great job. Samin, final points from you?
That's it. I think this is, we say in the life, many things come full circle, and this is one of them. That the brachytherapy we thought was kind of dead, but clearly, in my opinion, in this day and age, knowing more reliance on drug-eluting stent, that it definitely will have a role in a very limited segment, but definitely in the cath lab, so that more and more cath labs will start having it. And but clearly, this option should be given to the patients before they go for the coronary artery bypass surgery.
I think you've demonstrated it very skillfully that there is a resurgence and the need for this therapy to exist. Please join us. Our next session is going to be June 18th. Samin and Anu, excellent job, superb case, and we'll see the viewers next time.